When we're starting with that. Oh, okay. Before we go into the discussion of the outpatient ambulatory health services, we want to go ahead and pull up a poll, but let's hold that for a second because I was reminded Tracy had a question that we wanted to follow up. So the question that she had asked was, will we be starting the new intake procedures on 11/9? When you take a look at the dates on the service standards, it's dating when these are ready. So Bridget or Jackie, can you take yourself off mute and answer that question? I think the answer is yes. They're going to be active after we're done with this, but I just want to make sure that that is correct.
That is correct.
All right. So now that you're getting your training, you will be ready to roll. Thanks, Tracy, for re-asking the question.
Oh, okay. I'm sorry, but then, so at any point during these 2 days, are they going to kind of go over those forms?
That is not something that's included in the training, but it's a really great question of how is that going to be handled? Jackie or Bridget, had you thought about that at all?
Is Bridget on the line?
I don't, yes, she's on the line. Bridget, can you take yourself off mute?
Hello?
Yes.
That means I've been talking for a while and no one's heard me. Yeah, so those Tracy and group, they're examples that you can use. So, but if you need us to go over them with you individually, we can do that.
Oh, so you don't specifically mean for us to use those? My assumption was we were supposed to use those exact forms. But
yeah, it's some instances you can, and some are examples to show you the information that's needed that you should capture. But like for the acuity scale, yes, we'd like for you to use that, unless you wanted to make something similar to that. So it's just giving you kind of a platform to use.
Okay. I mean, but I'm not going to have time to make up our own between now and Monday. So my assumption would be is we would just use those.
Yeah, that's great. But if you need us to go over anything with you specifically, we can.
Well, yeah, and I see Philip has a question over there, some questions over there that maybe you could answer in the chat over there.
Yeah, on some of the standards it says required, and some of them are examples. So because they're 18 service standards, so in some of them it says it gives different verbiage.
Right, but when you look at forms I'm talking about is this client intake, and it says required.
Right. Okay. So that information would be required. Yes.
Okay. So then I'm asking then if this is required, there's like 8 pages, or was this something you guys were going to discuss?
Well, we didn't plan on discussing it today, but we can go over it with you individually if you need that. Yes.
Okay. So it sounds as if there is
Lori, let me say this. We have a year, you guys, to work through this and for training. So it's not like you're expected to, this is when they're effective for on November 7th, and we're going through the training. So the service standards, we know that some of it is really new for all of us. I'm going to say it like that. So this is your learning curve. So we have a year of working through these. Monitoring will not start until you've had your year of training. So this is a whole year of training with the service standards. So this is giving you time to get everything in place. So this is not expected. We're not expecting you to just start out tomorrow, but you have to take this back to your staff. Get everything set up in your office. So this is a process. It's not expected for you to start to have it all in place within a couple of days. if
Okay.
that helps.
So what I'm hearing, and let me just make sure that I have followed everything with this, is in the service standards, there are, depending on which service that we're talking about, some of them are, there's required information. And I think Leslie was capturing that. Information is required, not necessarily the form itself. And it sounds as if there is going to be a need to walk through the form to ensure that understanding and consistency in how to use the form, type of information to include in there. So that it sounds like it's a request. Is that correct, Tracy? That would be something that would be you guys would like to have?
Yes.
Okay, so that's a request there. And then what I'm hearing Bridget say is that we have some time as we're rolling out these service standards. This is a really great example of some points where it would benefit from additional training or technical assistance around it. And so plans can be put in place to address that. So I think that's great. Definitely keep those questions coming because that's really helpful with that. And then there's one other question that got put in the chat room, and it ties back to the acuity scale we were talking about earlier. And Jennifer is saying that she has her own acuity scale already in use. Is that okay to continue to use? So it's that interpretation of, is the actual form itself required, in this case, the acuity scale, or do we have the flexibility as long as we're doing an acuity scale, which direction do we go? So Bridget. I think, Bridget, are you looking back at the standards? We can't hear you, Bridget, if you're saying something.
Okay.
Oh.
All right. So I have to unmute myself on my phone and the computer. Okay. I wanted to just share that, yes, I would say that your acuity scale, if it's equal to or better than what's already in place, yes. We've been talking about the acuity scale for a couple of years now. Generally in our ADAP quality meetings, we've announced it. I think some of the agencies had already started migrating and adopting the acuity scale. We shared with all of the providers that Virginia had a system that we thought was really nice. And so I hope I answered your question, but yes, if it's equal to or better than what we have in place, I think that would be fine.
So that might be something that we want to explore a little bit more. And maybe it's, if you have an acuity scale, maybe that's a one-on-one conversation to have, because I know that probably some people may be like, well, how do I know if it's equal to or better? Like my interpretation may be a little different than somebody else's. So what I would probably say, let's see, Jennifer, is maybe if you've got that acuity scale, why don't you share that with Bridget and the team, and they can take a look at that, and that way a decision can be made around that. And then if other folks are using other acuity scales, a similar process could work. Would that work for you, Bridget? And you're back on mute.
Yes.
Okay, excellent, wonderful, thanks. All right. Anything else before we go ahead to the poll? Great conversations and great clarification. No? Okay, so let's go ahead and let's do another poll. Kate, can you go ahead and pull this up? We want to get that sense of how's your experience going so far. So this time we give you more options in here. Let us know in the chat if something else is, you're feeling something else. And this is one where you actually can do multiple choice, because you may be having a bunch of different things that you're experiencing in the morning. Do you feel like you're crying? Are you sleepy? Are you happy? Feel like we're going in the right way? Are you excited about having this? A little curiosity there about, kind of neutral. I don't know. I'm not exactly sure how I'm feeling at the moment. Confused. Are you confused? Like, I'm not really sure what I do with it. And if you have confusion, would really love to see some comments in the chat room so we can help include that. Is your head spinning at the moment, or are you angry? Like, oh, goodness, all of this stuff that's kind of coming on. Let's get a sense of where we're at with it. We're about 42% voting right now. So go ahead, let's get a sense of where you're at. And a reminder, if you're a co-host, you cannot vote. Don't hit that button of end the poll. We want to get a sense of where everybody is. I think there's a range of emotions that are out there. So I'll give you about 63%. And let's see if we can hit that 70% response rate. Would love to have that, because it's always nice to see where everybody is at with this. We are close. One more person will probably tip us over there. Let's see, we've got 45 out of 66 people who have voted. Can you give me one more? Who hasn't voted yet? Throw your hat in the ring and let's get a sense of where we're at with this. It's some interesting reactions of kind of where we're at right now. All right, so I'm going to have the poll closed in 5, 4, 3, 2, 1. We'll go ahead and I'm going to end the poll and let's take a look at what the results are. So it's actually really interesting to see where people are. We're over a huge spectrum here. The majority of people are kind of neutral about this is how I'm feeling at the moment. We've covered a lot of ground during the day. We've got some folks who are happiest. We've got 24% who are a little curious. We have some folks who are a little confused and a little head spinning. That's probably indicative of the conversation we just had in terms of what are the forms, right? Like, so we've got 4% that are actually angry about kind of what heck is going on here. And I got 2%, one person who's crying. I only have 7% that are sleepy. So that's a good thing, right? So with that, and this is really helpful. Thanks for playing and thanks for sharing what, kind of how you're feeling with this. And this is really important. This is something new that we are rolling out right now, and it's going to take a little bit of adjustment. And I really liked, Bridget, what you were talking about in terms of, yes, we have a start date of Monday, these going live for us using them, but there will be a period of adjustment. And as we go through the adjustment, making sure that there's that communication and flow so that we know where are those points of clarification. We've already identified several frequently asked questions that we'll be able to respond to so that other people can hear some of the questions as well. And this afternoon conversation has added to that. And so we're already putting some plans into place to make sure that you have the information you need in order to be successful to implement this. So keep the dialogue going. All right, thanks everybody. So let's go to the next slide, and I'm going to go ahead and turn it over to you, Justin, so you can take us through our outpatient ambulatory health services. Thanks.
Thank you so much, Lori. And thanks to all of you. We're really in the home stretch here. So, with that, we're going to keep going right through. It's outpatient ambulatory health services. So as we mentioned right off the top of the meeting today, that OAHS is just such a huge category, right? We can't possibly cover, every clinical standard, every test that needs to be done in the limited time we have here today. So what we really, our goal here to do is to just kind of give an overview of all the diagnostic and therapeutic services that are available. So the most common things and services provided by a licensed physician, a physician's assistant, a clinical nurse specialist, or a nurse practitioner. So I think the important thing to keep in mind here is like I said, a lot of this is not unique to Alabama, that there's national standards, public health service guidelines that kind of mandate a lot of this. But it's kind of, I think, thinking forward of implementation and monitoring. How do these play out once the services are implemented? And just to include, I think setting is something I really want to talk a little bit about today. So the services can be done in very traditional doctor's office, clinics, you know, outpatient settings in hospitals. Those are all common areas where we could see OAHS delivered, but also mobile vans, virtually using telehealth technology. I think that's an area folks are running into even before COVID, and it's probably expanded now. So what kind of services can we provide? So the standard details of diagnostic lab testing, early intervention and risk assessment. And again, as we covered back in referral and early intervention, that if it's delivered under those service categories, it wouldn't be included, right? So you can't kind of double up. So if it's something that occurs as a part of a routine medical visit, then that would fit into OAHS. And if it's something that's kind of happening in more of a support service setting or ASO setting, then that, you know, would fit better under those categories. So preventative care and screening, physical examination, medical history, diagnosis of treatment and conditions, prescribing and managing of medication therapy, education and counseling on health issues. And again, that's within the medical setting. So, you know, not overlapping with other services such as HERR or EIS that we also will cover. Well baby care, continuing care and management of chronic conditions, and referral to and provision of HIV related specialty care. And that includes subspecialties such as ophthalmology. We know that as the disease progresses, you know, it has some effects on eyes and things of that nature. And last but not least, treatment adherence that can be included as part of OAHS as well. This looks pretty good to everyone. No big surprises here, right? Awesome. Let's move along. So what are the key topics on how we're going to deliver all that long laundry list of services we saw? So today we're going to focus on documentation, a little bit on the physical examination, some of the required components there, the conduction of follow-up visits, and last but not least, some basics on testing and screening. Next slide, please. So OAHS documentation. Again, all OAHS is documented within the client record. And so we talked a little bit this morning about the record retention policies and within the universal standards, like what goes into the documentation. Well, OAHS has some things, you know, above and beyond that also fit into that client record. And I think, you know, it's one of those ones that's a little bit more standardized already. I think there's a lot of other requirements, state, local, federal requirements, how we provide healthcare. So, you know, every client has a chart, whether it's paper, electronic. These are the things that must be maintained within that record. So we're going to have a referral, an initial assessment, an individualized treatment plan, including treatment modality and frequency and quantity of treatments, documentation of all contacts and dates of service, reassessment of treatment plan to include monitoring and assessment of client progress, referrals and follow-ups, and a discharge plan if applicable. So the important thing here is that all reports must be signed and dated. As is a medical service, you know, it's really important that we see that the type of folks with those clinical certifications are doing the right type of services. So, you know, I think documentation in and health services is kind of, it's, you know, we think of like a chart review, right? So there's, you know, as this is being monitored, it's kind of a common thing that that we're kind of used to. Does anyone have any questions on documentation? Do you see anything that's missing that, you know, should be included? Anything that you're here like, oh, we don't do that? All right, I'll take that as yes. This looks pretty familiar. We'll keep moving along. Next slide, please. So actually doing the assessment, service plan, and providing the services. What are the key things to keep in mind when providing outpatient ambulatory health services? So a medical treatment plan is developed in collaboration with the client. The client is offered a copy of the medical plan. And again, this should feel kind of familiar with what we talked about this morning in the big group with the medical case management service plan. So kind of the same thing is as we outline our goals for treatment, we want the client to be an engaged partner in that. We want them to be aware of their rights and responsibilities and, really meeting their critical needs. So it's key that the plan is developed with their input and they're aware of how to proceed with it. So as far as how frequently these plans are updated, medical care plan is updated every 6 months or more frequently as needed. So obviously, if you have a newer client or a client with a lot of changes in their health status or other conditions, that would maybe require more frequent updating. Next slide, please. So the next area we're going to delve into is follow-up. And, after that initial appointment, we're going to think about testing and screening. So the provision of all services must be in accordance with HHS HIV treatment guidelines as part of treatment of HIV infection. And again, if you're not familiar with those, I highly encourage you to check them out on the website. They're all listed there. They go into much greater depth than we are going to cover here today. It has a lot of detail on each one of these bullets here. So things like labs, screenings, risk assessment, preventative care and screening, physical examination, regular visits, behavioral risk assessment, access to ART, treatment adherence, and education and counseling. So, okay, so this is an important point. What is not covered under OAHS? So some things would be complementary or alternative treatments, including chiropractic care, massage therapy, hypnotherapy, and acupuncture. So those, those would not be covered under Ryan White OAHS. And there's some other Ryan White services where there are some small exceptions for some of these, but not in OAHS. And we'll cover those when we get to the appropriate. Oh, yeah, Lori's got it. So similar, but a little bit different. And then the other thing is that because it's outpatient ambulatory, we're really limited to outpatient services. So no inpatient medical services. That would be emergency room services, pharmacist consultations, or non-HIV related visits to urgent care facilities. So those are the exceptions. And so, as you're working with your clients, you want to make sure that they're aware of that. If they are funded under Ryan White, that's that's always one. Long ago, when I was in a clinic, that was always, we'd have people who go to the emergency room, and it was always a surprise for everyone. So keep those in mind. Next slide, please. So that's really it. We kind of only covered the essentials of OAHS, things that are important to keep in mind, things that are kind of unique and above and beyond the HHS service guidelines. So really, I want to thoroughly encourage you to check those out for a little bit more detail. We have the link right here. You can click on that and certainly let us know if you have any questions. So we want to ensure the client medical records document the service provided, the dates and frequencies of service provided, and that services are for the treatment of HIV infection. So that's an important thing to note. As we mentioned back in the documentation slide, you have a lot of freedom. There's not a ton of requirements in how they're documented. We know everyone has different systems, paper, electronic, different electronic systems. The key thing is that they're being captured. You're capturing the dates, the frequency provided, signed when appropriate. And so thinking about the clinician's note and what that includes, so it is in the patient record and it is signed by the licensed provider of services. So that's a really important thing to keep in mind. Next is to maintain professional certifications and licensure documents and make them available to the grantee upon request. So this starts to get into monitoring a little bit, and also keeping in mind, back in this morning when we talked about universal standards, we said that the appropriate level of licensed staff is needed. And so with medical, if you were to have a monitoring visit, they could come in and see the licensure was available for review. And last but not least, document all services in the client medical records. That is the kind of the main place when we look at the monitoring of the standard where these things are being captured. So you want to, if it happens, document it, right? If it's not documented, it didn't happen. Next slide, please. So, ready to see what you learned or what you already know? A little brief quiz. Everyone ready? Ready to test your knowledge? I know it's the end of the day. It's been a long day. All right, yeah. Next slide, please. So our first question is which is not an allowable setting for OAHS services? And your selections are A, mobile vans, B, clinics, C, virtually using telehealth technology, D, the ER, or E, all of the above. I'm starting to see answers coming in the chat. I like that. So yeah, everyone seems to be coming in with the consensus around D. So D, the ER. Can you click for me? Yep, the answer is D. That's correct. So again, as we kind of talked about in detail, the ER is not outpatient, so it would not be considered an allowable setting for Rhineway OAHS services. I think I made these too easy now looking back. Next question, please. I mean, or you guys are just a really smart group, or a little bit of both. So treatment plans. How frequently should the treatment plan be updated? Great, I'm starting to see some answers roll in. And again, we seem to have a lot of consensus. We're looking at letter C. Can we find out what the answer is? Letter C. So great job, yes. The treatment plan should be updated every 6 months. And so someone on the line providing OAHS services, would you like to, tell us a little bit about it? Does that seem like a good interval? How does this play out in the real world as we implement these services? Does that make sense? And feel free to type in the chat. You can take yourself off mute and just tell us a little bit about your process for updating treatment plans and if this makes sense.
I think we've got the end of the day of fatigue setting in, Justin.
Yep, we can go ahead and move on. You guys know this stuff. You're doing great. So this one, please disregard the title here. So which are components of physical examination? So choose any and all that apply. So it might be more than one. So physical examination is A, medical assessment and history, B, referrals, C, health education, and D, drug allergies. Which one or which a couple of them are part of the physical examination? So I'm seeing a little bit of variation here, some A and D, some A, B, C, D. So I'm going to give folks a few more a little more time to weigh in, because with this one we have a little bit of variation on. Oh, wow, we're kind of all over the place on this one. So ACD, I'm seeing a lot. I'm seeing a lot of ABC. Okay, I think maybe a plurality has coalesced around ACD. So can we go, you guys ready to see what the answer is? Unless it's a medical referral. Go ahead. So I have A and D here, but Melissa actually brought up, excuse me, Melissa brought up a great point that if it is a medical referral, would it be included in the physical examination? So definitely drug allergies, definitely medical assessment and history, health education. You know, that's can be a component of the service, but not necessarily the physical examination. And I believe the same goes for medical referrals are included. I'm seeing.
Looks like that may be an FAQ to do some delving into it. What are the components of that?
Yeah, I think that would be a good one when you're thinking about the listed criteria and how medical referrals fit into that. So we'll circle back to that one in our FAQ. Next slide, please. So that's really it. Thank you for hanging in there with us. If you have any questions about the OAHS guidelines, feel free to let us know. I know we kind of covered that one, just the basics. There's a lot of clinical requirements in there as well that we didn't, dig deep into just with the amount of time and expertise we had. So any other questions?
All right. Well, it doesn't look as if we have any questions around that. Thanks, Justin, for walking us through that. And as I know you already talked about, it's really hard. This is more of a surface review as we think about OAHS and all the elements that are included therein. Take a look at the service standards and let us know if there are questions afterwards that come up with this. Let's go to the next slide. And we're going to roll right into our wrap up for the day. You guys have been troopers staying with us all the way through to this point. Here we sit at 3:14. We've still got 71 participants signed in on the call. So it's excellent. And I know it's really hard to do this in a virtual setting. So thanks, everybody. What we want to do right now is, and Kate, you can go ahead and take the slide off. We want to talk about pluses and changes, pluses and deltas, thinking about what worked well during the day. And so and I'm going to take them separately. So what pluses do you have for us? Feel free to drop them in the chat room or take yourself off mute. What worked well? We always use this as a way to kind of readjust and plan for the next day and for future training. So what worked well, guys, that you want us to continue?
I like the, hey, this is Krista. I like the rundown of the Zoom functionality in the beginning, even though a lot of us use it often, many of us don't. And so even this is my first time locating the reaction button because nobody ever pointed it out to me. So I never used it before. So I like that part of it.
Great, thanks, Krista. And I can't believe that you actually said that, knowing how well you jumped right in and did the annotation. I mean, that's incredible.
Well, thank you. Thank you very much.
All right, excellent. Well, thank you. Anybody else want to share some pluses that worked well? I see we've got a couple things in the chat room in terms of the polls and quizzes that helped to kind of break things up. The questions were great, slides were helpful because I'm a visual learner. Gloria, I am right there with you. You can tell me something and it's going to make a big difference if I can actually see the darn thing. What other suggestions do you guys have? Links to the chat, excellent. So you liked getting the files dropped in, both links as well as the actual PDF files for the specific service standard we're looking at? Links and files, okay, excellent, thank you. Wonderful. We didn't want to bombard you and say, oh, here's 17 different service standards, guys, have fun, because it's over 200 pages or, you know, whatever, but little drips and drabs here. Of course, the slide set, yeah, today was 158 slides, a lot of ground we covered. Okay, the surveys as well, interactive stuff is energizing. Wonderful, thank you. Anything else with that before we go ahead and change to talking about what we'd like to see improved for tomorrow?
Great presenters. I really enjoyed the presenters, very professional. The quality, the clarity, it's just awesome.
Great, thanks, James. And I see Terry put in there, the icebreaker was great. Need another one after lunch. You are right. We drove right into the breakout group. I think tomorrow, I can't remember how we have it set up. I think we might have something in there, but if not, oh, actually we do. Is that the personal weather forecast, Justin? Okay, so we got something to think about. Where are we going with that one? All right, excellent. Thank you guys. Anything else before we go ahead to changes? Okay, so now let's shift gears. Let's talk about what are the changes. What would you like to have seen differently? What would you like for tomorrow? Oh, you know, Krista, I am so totally with you on that, of having the music. We got to do that for tomorrow. Absolutely. Kate, do you think we can get something lined up? I like that. We'll have to do that. I was actually doing a learning session for Las Vegas Monday and Wednesday, and that was what we had. And we kept coming in, and I forgot that I was on video screen. So as I was listening, I'm bopping around, I'm doing my table, you know, my chair dance and everything. So we will definitely address that, Krista. Thank you. What other things? Don't be shy. Quality improvement hats here, guys. Always looking to do something better. Krista.
I was gonna say, if people, we need to make sure that we've updated to the most current version of Zoom. Maybe we could get that in an email beforehand, because that's not something that I check on regularly. So in order to get that little pop-up box, that information that you gave us about why our pop-up box might be missing when it was time to join the breakout rooms, that would have been good information to come a little bit.
Great point. I love that. So maybe over the evening we can go ahead and get you a link and make sure that everybody has a chance to update that. Wonderful. All right, more ways to encourage discussion and audience input. Melissa, how would let me take you off of mute and let's talk a little bit more about that. How else can we do that? I know that it's difficult at times in this virtual setting. Is it talking with folks? Go ahead.
Yes, I guess maybe asking more questions like the way you have been doing, and like at this, you know, instead of just plowing through, maybe stopping in. Like, I know we're doing the quizzes, but maybe pose a question. How many have been doing this already? Let me hear from you. I don't know. I'm not a provider, but I know when I was a therapist, that usually get people at least loosen up and talking if they get to know about what they're doing in their own clinic, and that may break the ice. And as Kathy Gaddis said in another session, they're all shy, so it might be break the shyness.
Yeah, you guys are a shy bunch. Even when we've asked folks to unveil themselves, we only had a couple people who were willing to do it. So maybe for tomorrow, but I also know, and thank you, Renee, for commenting on that. I know that some folks just don't have the video capability, and that is what we're dealing with as well. So we have that kind of struggle that we can't see people, but for those who can, maybe that's an option and an opportunity. You know, it's actually really interesting. I've seen a lot of jurisdictions who used the CARES Act funding, the COVID CARES Act funding, to outfit their agencies with laptops, video cameras, things like that, so they can do more of this virtual interaction with the clients as well. Don't know if that's a something that the Department of Health can look at or not, but I know a lot of other places have done that. So important to kind of know. Other changes that we can carry over into tomorrow.
Get us to stretch or stand up and stretch or something like, just to take a
Yes.
deep breath and relax and loosen up.
I'm with you there, James. So we will add some of those energizers, get up, let's move around, so that we can have that. I like it. Some practical walkthroughs of how actually some of these things get implemented. Tracy, can you take yourself off mute? Talk to me a little bit more about this. I'd really like to see, you're feeling overwhelmed, and thank you for sharing that. This is overwhelming. And especially when there's some areas where it might be some, lack of clarity with that. And like you were saying, the intakes form and the acuity scale. And I think what was really nice, what I heard from Bridget, is it doesn't have to happen tomorrow. It's this is what's coming. We're doing the training so that we can unveil it all at one time, and then we'll take those incremental steps. And thinking about, it's an elephant, right? And how do we eat the elephant? How do we eat the elephant, guys? I know somebody knows it.
One bite at a time.
One bite at a time. That's right, Melissa. So think about the service standards and all of this work as the elephant. It's the elephant in the room, and we're going to take some small bites out of this. We've actually taken a pretty good chunk today, started to nibble on the ear and everything. We haven't quite gotten to the neck or to the trunk, but that's how we'll handle this. And I think it's really important to acknowledge that it can be overwhelming. And I'm really glad that we did the poll to see how are people really feeling about this. Because if there is a lot of anxiety and confusion, even some anger, and not really sure where, knowing where we go with this, that's important to think about how we all collectively take that next step forward. So thank you, Tracy. I really appreciate the comment. And Gloria kind of weighing in on that as well. Anything else that you guys would like to share in terms of what you'd like to see changed for tomorrow?
Did you want me to comment on that?
Yes, if you're willing to, absolutely.
So, again, and I feel, I think what's making me feel even more anxious is that, and maybe it is, maybe people are just shy, that no one else is asking questions. So it makes me feel like everyone else already understands all of this. So I'm like, oh gosh, but like I was just looking over that acuity scale, and it's like 8 pages long. I mean, it would probably take a good 45 minutes to complete at least. And just kind of trying to figure out how that's going to like practically work. Like, and I mean, a lot of patients are not going to want to sit and do this entire intake and then go through probably 50 to 100 more questions. And I'm just trying to figure out. So again, just kind of like, yes, I know we need to go over the standards, but also, oh, I meant for you. Can you see me there? So, but also for, some like how this is actually like how other people, maybe if they're already doing it, like how are they implementing it? Show me your form, show me exactly what you're doing. And if we're going on tomorrow, like how these things are actually getting done.
Great point. I love that. And you're really talking about building that community of learning, right? That we're in this together. How do we learn from one another? What are you doing? What's the tool that you're doing? How do you operationalize it? How long does it actually take you to complete that? Jennifer talks about that they're using that as part of the intake, having an opportunity to really talk through how is that done? How do you weave in the questions in this intake and to come through so that you have the acuity scale? And so I think what I'm hearing you say, Tracy, is in addition perhaps to having the opportunities to dive in deeper and get a training of if there are required forms, kind of talking through what they are, how it can be used, questions that may come up as a group with this, and also for tomorrow, thinking about what are some of the questions that we can begin instilling some of this dialogue already. So thinking about for tomorrow, how do we do that?
I just want to comment that my experience and when you're doing assessment is that as you're doing your psychosocial assessment or your assessment, you're probably already getting answers to the acuity questions. So it's not like you complete your assessment and then you go start one through whatever on the acuity. That I think it's kind of interactive and your answers come along the way. So I don't think it's going to add a significant amount of time to what we're already doing.
Great.
Okay, and I mean, yes, thank you. So that's a very good answer, because, you know, in my mind, I'm thinking, are you going through these 8 pages and asking every single one of these questions? Okay. Okay.
Great. Thanks for asking the question, Tracy, and thanks, Carol, for kind of jumping in as well and talking about how it is and how you can operationalize and streamline it. And part of that is looking at the form to see what the questions are, how do we use it, and there may very well be a good portion of them that can be addressed as you're going through, and maybe there are a couple that aren't something that you're already looking at. So thinking about where and when you pull that in. So great questions. And Leslie is also kind of agreeing in terms of really going to have to look at how do we implement these. And I think that was one of the things when we talked about this at the beginning of the day and a couple times throughout is it's one thing to present the information and walk through with the service standards. You can get a sense of it as we're talking, but the rubber meets the road where? It's when you're actually trying to use the materials and put them into place. That's where you're going to get a different level of questions and thinking through how do we actually use all of these materials. And so we want to keep that dialogue going so we continue to learn from one another about what works and what is not working.
Right.
Bridget?
I'd like to add the Health Services Center was a part of our subcommittee group. Kelly Turner, I think they've already started using the acuity scale. So like you said earlier, Lori, building your community, we're happy to do TA too, but then Tracy and others, you have other organizations that are using it and they would be happy to help, I'm sure. I don't know if Kelly's still on the call, but you know, I know she'll be there to support us.
Yep, she's weighing in the chat room and saying yes, she is. So that's great to know.
Great. Thank you.
Wonderful. All right. Good point, Justin. Do you want to take yourself off mute there and just talk a little bit more about that, and then we'll go ahead and move into the final phase. Go ahead.
Yeah, I was lucky enough to be part of a couple different EMAs when they introduced the concept of an acuity scale. And at first, I think it was really overwhelming, and there was kind of outrage a little bit more than I'm seeing today, if I'm being honest. And it's a long form, and it is time consuming. So thinking about it more as, as kind of a basis, like there's a little bit of overlap on the forms, and it's more just getting a feel for the client, learning, what you need to learn about them. And, if they're one of those 4 categories, then you're automatically going to know, okay, they're already high acuity. So I wouldn't, need to go through the form in detail. So think about it, the more you do them, the more I think you'll get comfortable with them. But think about it as just more as a learning opportunity, a conversation, than asking every single question. And I think that you'll find it a better experience. And the nice thing is, if everyone is using something the same or similar, it's better continuity for the client. It's better continuity for case managers. They maybe move around, that we have a better understanding of our caseload and our needs assessment. If we're seeing like, wow, there's a lot of high acuity because there's a lot of peri-incarcerated folks. So, the data collection part of it too can be helpful down the line. But yeah, I feel for you.
Great. Thanks so much, Justin. And yeah, I was also have worked with different jurisdictions and states where they have introduced this. One of them up in Massachusetts where they tried to do it. And it was actually a 3-year project. And what was exciting though was that once they did it and they standardized the acuity scale across their state as a whole, they really are able to make different funding decisions because they have a much better sense of what is the acuity level that their clients are appearing with and how that changes over time. Because as we know, a client could present with say an acuity score of 1 today and 5 a day later because of what's happened in their lives. So, and Kathy's bringing up a really good point of thinking about if they have to do this more than one time, how do you do that? So that there is not this like we can talk about it, over screening, over assessment, how many times do you have to go through this same discussion? So I think those are really important of how do we actually operationalize something like this. So lots of fodder for future conversation, but I love the fact that the discussion has started today. So nice job, everyone, in bringing those to the surface. Let's go ahead. Kate, can you pull up the slides? Let's take a quick glance at what we're going to do tomorrow. And then we'll go ahead and see where we're at. So for tomorrow, go to the next slide. We're going to start just a little bit later. You still have the opportunity to log in. We will have the login is available 30 minutes before the training actually starts, which will be 10 o'clock Central Time. For us on the East Coast, it'll be 11 o'clock. And so we're going to run until 3:30. We're going to start off with just a real brief overview of what we're going to do for the day. And then we're immediately going to go into our breakout groups. And we have 2 groups as well. Justin is going to go ahead and talk through 3 service categories: linguistic services, psychosocial support, and health education and risk reduction. And then I'm going to take oral health and health insurance premiums. So we'll use this 2-prong approach with these breakout groups. And as part of that, built on what we've talked about today, what I'd like to be able to do is actually dive into that discussion about how do we actually implement some of these service standards. So I want you guys to put your thinking caps on over the night and think about how would you approach these, knowing we're going to be looking specifically at those service categories. Then we will come back. We've got lunch built in there as well. And then we will be talking, we've got food bank, EFA, and medical transportation. With that service categories that we're going to look at, and then we'll go ahead and wrap it up. We do want to spend a little bit of time talking about technical assistance. What are your needs? We've begun this discussion as we're already starting, so we've got some really great ideas of where we can go with this and get us thinking about how do we actually use these standards, and again, an opportunity to do some wrap up and some reflection on the not just day 2, but the training as a whole with that. And just clarification, so we have 10 o'clock Central Time. Is it daylight or standard? I never remember when we do the time zones, but it's 10 o'clock your time. And for Justin, Kate, and I, we live on the East Coast. So our time is an hour ahead of you, right? We're 11 o'clock, yeah. I'm not good with time zones. So that's how the timing will work. Let's go to the next slide. One other thing we wanted to let you know is when we were crafting this training, there were 3 categories that had very few provider agencies funded for it. And this relates to housing, other professional services, and outreach. What we are going to be doing is we are actually going to be recording sessions outside of this, and they will be available for any of those agencies that are funded for these service categories. So if you thought we forgot about, and the answer is no, we actually made a strategic decision of how we wanted to use the time most effectively with the largest group. So stay tuned for that. We will be doing that, and we'll let you know, Bridget and Jackie will let you know when that has been completed and is posted. Let's go to the next slide. So let's do our final poll of the day. Let's get a sense of where we're at with this. And let's see how we're doing. So if you can pull up the poll, Kate, this one actually has a total of 3 different questions. The first question, you answer them all at the same time. How relevant was the information that was presented? Was it very relevant, somewhat relevant, not so relevant, or not at all relevant? Second question was what was the balance between didactic content and interactive? Was it too much us talking at you? Was it just the right balance, or too little, too much, right in the middle? So kind of like the Goldilocks. And then the third question is, did you have sufficient opportunities to give input and ask these questions during the meeting? So let's get a sense from folks of how are you feeling about these? The poll disappeared. I'm seeing the poll. Is it the poll showing for everybody else?
Yes.
Yes, it is. Okay. Marvelous. I'm not sure what happened with yours. Okay, so Terry's seeing it.
Take a look if you've minimized a window, something might be hidden. So take a look and see, because it's a pop-up.
Thank you, Kate. So good that we have Kate who can walk us through those. And thank you, Kate, for the number of people I sent you where we had problems with the phone and pairing. All right, so Justin is saying it just reinforcing that point. It may have been minimized. If you click on the poll again, it should bring it to the forefront. All right, excellent. There we go. 2-second TA, I love it. All right, so we are right now 55% of the vote in. We've got 59 folks who are still on the call. Let's see if we can bump that up a little bit more. Again, we use this. Be honest of, how are you feeling with this? You guys have been doing great so far. So this is the very last thing we want to see with this, where we've hit 67%. Let's see if we can tip it over to that 70%. Oh, we're up to 69. Let's see if we can get one more person in. Let's go. We got one more. Let's see if we can do it. Oh, we just hit 71%. Nice. We're going to go ahead and close the poll in 5, 4, 3, 2, 1. Cast your vote right now, because we know that once it's closed, right? But at least we can see our results a little bit quicker than something else that's happening out there. So let's go ahead. We're going to end this poll and let's take a look at where we're doing, where we're landing with this. So it looks as if the information was relevant, that there was a good balance between the didactic and interactive exercises. And then we've got the sufficient opportunities, saying that for the most part, people agree that they did have opportunities to ask those questions and provide the input. And I know we roller skated through a lot of information in the morning today, and hopefully we'll have a little more leisurely discussion during tomorrow. All right. Kate, will you go to the next slide, please? So I just want to say, from Organizational Ideas, thank you everybody for your involvement and interaction and engagement in this. You've been tremendous, and I love all the dialogue that we've had. Let me turn it over to Bridget and Jackie to see if you guys have any remaining questions before we go ahead and close for the day.
I would just like to say thank you for everyone's participation and questions and involvement, and I look forward to seeing you all tomorrow.
Wonderful. Thanks, Bridget. Jackie, Justin, or Kate, do you guys have anything?
I agree with Bridget. Thank you all for participating and look forward to seeing you all tomorrow.
Wonderful. Thank you. Justin?
Yeah, thank you all again. It was great getting to interact with new folks. Get prepared for more of the same tomorrow. You all were real champions and hung in there. So we're past the tipping point here. So it'll all be downhill, and we can coast into the weekend feeling confident about our knowledge of service standards.
There you go. Well, wonderful. And on that note, I hope everybody has an enjoyable evening. You actually have a gift of time. If I can ask Bridget, Jackie, Melissa, Kate, and Justin to stay and just whisk us into a breakout room so we can go ahead and just do a final debrief and prep for tomorrow. Thank you, everybody. We'll see you then.
Bye.